Sure. So, today I will be talking about a cath lab procedure which is commonly done in all the cath labs. So, balloon pulmonary valvuloplasty for the newborns. I will try to share my experience and in difficult situations, how do you manage those situations? Let us try and understand what are the tricks and tips to understand neonatal BPV. So, regarding, I'm starting with the first case one to give a glimpse that we all know PS can be diagnosed in fetal life. And this is a fetal equal 24 weeks gestation. And you can see there are two short triple vessel views. Skin on the left side shows PA aorta and SVC is called PASS algorithm. And this is normal fetus pulmonary valve, where pulmonary artery is normal sized and slightly bigger than the aorta, and then aorta is bigger than the SVC. But on the right side of screen, you see this again a triple vessel, simultaneous triple vessel view, and you can see a significant MPA dilatation, which is significant post-unit dilatation. Somewhere here is the valve, and you can see a significant post-unit dilatation. So even if you don't get Doppler across the pulmonary valve, you would get the dilatation in a lot of the cases of fetal PS. So you can diagnose fetal PS by a simple marker in triple vessel view. Now this fetus was born to us with the dilated right heart chambers and oligemic lung fields. And at birth, sat 75% mild distress. This is the echo after birth. You can see the RV dysfunction is severe. So, IVS bulging to the LA. Significant dysfunction of RV are seen at birth. So the dysfunction was not that much at 24 weeks of life, but during the course of pregnancy, the RV has gone down. This is the understand the pulmonary valve. The pulmonary valve has become calcified during the fetal life, and there is barely a antigate flow. So what we learned, it is a long time back case, around 2011 case, and at that stage we were saying if you find a PS patient, they no need to follow up. Anyway, you are not going to do anything. But now we tell them to come every 4 weeks to understand antigate flow, how much antigate flow is there, how much the RV function is there, so that you can take a decision where to get delivered. Suppose the antigate flow is very less during the course of pregnancy, then you tell them to get delivered at a center where immediate BPV can be done. Otherwise, if the antigate flow is good, they can get delivered and come back to you with the baby. So that you can change few things, scenarios in the fetal life also in such scenarios. This patient underwent routine PG infusion to open the ductus and BPV. So long time back, I had a Burman also that stage to see the RV. See the RV dysfunction is huge, and you can see some TR for the all the DNB students if they are there. You can see the TR can be picked up. The RA is being filled here. Then this is the because catheter is coming from IVC to RV, so somewhere here is the RA, and you can appreciate the TR, degree of TR, severe TR, and then antical flow is very less. This is antical flow, but ultimately we could do the balloon. So during the routine procedures of BPV newborns, critical patients always arrange a blood. General anesthesia unstable patients or critical patients. Annulus measurements, you should know how to take the annulus measurement. At the end of systole, at hinge points of valve leaflets. Normally I do by echo, but a lot of people compare it with angio images. In newborns, I rely more on the echo images. Balloon annulus ratio should not exceed 1.2. You try to go 0.8 to 1 only. 1.2 is slightly on the higher side, but it should not go beyond 1.2. So measure the annulus properly so that you don't underestimate size of annulus and don't overinflate the balloon. Then RV angiogram, not always done, but if the kidney renal function are okay, I want to have a RV angio to assess annulus, infundibulum, and the anatomy of valve. So lateral view. Here, for the angiogram, you can use Burman, availability issue. You can use ionless catheter, which is commonly available, or MPU side hose can be also be used. Normally, in newborns, hand injection should suffice actually. You should not need a injection through the injector. And then if nothing is available, you can use a pigtail. The pigtail can be put into the RV, and then you have to use the injector to do the injections. Now, during you're doing the RV angio, you make sure that you have crossed the valve, tricuspid valve, through central orifice and not through chordae. Now, how do you make sure is a difficult answer. But if your catheter is not going over the wire and you're needing resistance, you don't push it. You cross it again actually. Because if you go through the chordae, you can lead to severe TR. And if you have hand-hold balloon-tipped catheters like Schwann-Ganz, then you can avoid crossing tracheal chordae. So, uh, preferable to use a balloon-tip catheter. If not available, then don't push the catheter over the wire. That is a very important part, especially in the newborns. Now, crossing the pulmonary valve, normally you can use thermo wire with MPA or GR catheter. Floppy tip guide wires can be used, PTC wires. Normally we use PTC wires. The important part is Cook's GR catheter. Curve is important because the curve is acute here. So straight curve catheter will not help you. So you need a good catheter. And I have found Cook's GR 2.5 centimeter curve is very good catheter to point towards pulmonary valve. This is one of the tips which we share in our group. Now see this patient, the angio. So when you are not able to cross, the valve is here. The catheter is so straight. This slip catheter, there is no curve, and you have gone straight. This catheter will never allow the crossing the pulmonary valve. So when you're not able to cross, just check with the hand injection. Confirm position of catheter is pointing towards valve before trying to push through the. And also rule out, this will rule out you have not gone through the RV myocardium, pericardium, basically. Then if the catheter is not tracking over wire across pulmonary valve, change of catheter to soft catheters, you cross the wire across the pulmonary valve, but catheter is not tracking over the wire. There are 2-3 methods which can help you. One is change of catheter, soft slippery catheters like glide catheter or slip catheter available in all the labs. I think glide catheters are always available in all the labs, commonly available, and they're useful. So keep those things on the table when you're talking about a neonatal BPV. It's a very important part to be in the lab. You should have a fresh new catheter of glide in the lab when you're doing the neonatal BPV. Second thing, sometimes placing the wire in ductus, because ductus is open in the most of the cases, placing wire in ductus may give better position for catheters and balloons. I will elaborate this on more. I use it very commonly actually. I will elaborate more on this. We try to place the wire in ductus. Now here, sometimes, if the balloon is not going over the wire, ductus give a strength like this. So my wire has gone through the pulmonary valve and then gone into through ductus into the descending organ. This long course of wire that gives more stability, and then lot of things can be managed and pushed across the pulmonary valve. But this particular patient went through the PDA here, but the balloon was slipping back again and again. It's a coronary balloon, small length balloon we were trying to use. Because a critical PS, we were doing the guiding. Through the guiding, we used guiding was placed just below the valve to avoid slippage of balloon again to RV. So we use the guide catheter and then coronary balloon for the P dilatation or gradual dilatation of the pulmonary valve was used. So use the guide catheter is a very good practice if the balloon is not stable, because coronary balloons are mostly 1.5 centimeter and you need to stabilize the balloon. So if you can keep the wire in the PDA, one tip here, and second thing, you can use the guide catheter to initially dilate the pulmonary valve. But remember, guiding catheter, 5 French guiding catheter will take all the coronary balloons actually. The length is an issue. So you keep the catheter so the balloon doesn't slip back again. This is case 3. One more guide to cross the pulmonary valve. One more guide is PDA because the ductus is open. So in this case, see this, I'm doing the angio and I have very little antegrade flow here. You can see the tiny antegrade flow across the pulmonary valve. Now, we kept trying, but we are not able to cross the pulmonary valve with different wires. Then we use this technique called ductus. We kept the multi-purpose in the ductus and localized the valve, and then this wire was pushed across this valve, guiding using a guiding as a catheter like this. Next slide, like this way. So we kept injecting into the PDA, localize the valve, and then the CTO wire was being used to enter the pulmonary. You can see the wire is able to reach to the pulmonary valve here. And finally, we could enter the pulmonary valve. So here, the technique was using PDA injection as a guide. You can always use PDA as a guide to you can always use PDA as a guide to cross the pulmonary valve. I'm having some issues with this. It'll take one more second. The video is causing trouble to me. It's a long video. Hold for a second, I will reshare. So you can always use PDA to open the ductus. This way I will try to show this video. It's a long video, so sometimes this takes time to load. Like this, so this. So use catheter in the PDA as a guide. Now, this was the femoral venous route. Now, what is the other routes available to us? I have some question in chat box. Okay. Now, different access routes, if femoral venous route is not successful, what are the other routes we can use and when to use them is also an important question. So we are not able to cross the tricuspid or RV due to RV dysfunction or TR or arrhythmias or dysplastic pulmonary valve. Changing the access route may help. Among all these factors, what we feel TR and dysplastic pulmonary valve are two main factors. Severe TR and small annulus or a combination which is troublesome to cross the pulmonary valve. Now we have different routes available. One of them is transjugular, then retrograde ductal, and transumbilical. The all three routes are commonly used in lot of units where they are doing neonatal BPV and not able to cross to the femoral vein. Now, what about transjugular access? It may provide a better alignment to cross tricuspid valve and pulmonary valve. Like if you go from up, it's a single loop. Whereas if you're going down, you're having a double loop. So this is a single loop, smooth loop, which can allow a valve, tricuspid valve and mainly tricuspid valve and pulmonary valve. Both can be aligned well. Better alignment to cross TV and PV. And in newborns, 5 French sheath, up to 5 French is easily placed. They are bigger jugular veins, so you should don't worry about the size of sheath. You don't need more than 5 in newborns. Also, while doing balloon in transjugular route, loop is important. Shortening of loop can lead to instability of the balloon, and balloon can pull back. This whole system can come back, including the wire. So how to avoid shortening of loop? I will give you some example, and then we'll see. This is one of the cases where we're trying to go through femoral vein, and because severe TR was there, RA was stressed out, every time we were having SVT. Whenever we enter the RA, there was SVT by our all methods. So we thought, let's try some other methods where we may have some lesser loops. So we went through jugular route now, and see the loop is smooth here. And in one go, we could cross, because RA is not being stretched now. From transjugular route, you can go to a tricuspid valve. And also if the severe TR, the transjugular route will give a better alignment to cross the tricuspid valve. And then pulmonary valve was crossed. So this case particularly, now I'm trying to show the loop shortening. This patient, see this, I was trying to balloon down, and then the loop becomes shortened. It's causing stretch on the heart. See this. So to the begin with, I have kept a short loop. So then we kept a bigger loop. I kept the wire pushed towards RV so that this is length available for the balloon to use the wire. So I kept some wider loop by pushing the wire, not pulling. This wire is being pulled actually. You keep the wire pushed so that RV is sustaining the wire and the loop is bigger here. The loop shortening would not happen and heart stretch will not happen, which can lead to hemodynamic compromise. This child may get hemodynamic compromise if you keep the loop so short. So try to have a larger loop. Now so we discussed about femoral vein, jugular vein. Now we go to the retrograde route. This is another case. We're going through the severe PS, RBH, RB dysfunction. So we thought let's go through the retrograde route. Retrograde ductal route means went through femoral artery, localize the ductus, through ductus localize the pulmonary valve, and then from this you can easily cross through the same wires. Whatever wire you want to keep the cross here and do the balloon. So this patient underwent sequential balloon dilatations to the retrograde route. Ultimately, we could keep a 2.5 Teflon wire and a bigger balloon was used. So gradual balloon dilatation performed through ductal route. Now, this is our data about neonatal critical pulmonary stenosis. We had 15 to 21, around 6 years data, where we had critical PS of 21 patients total, 25 patients total. They were all critical PS, where either duct was being opened by PG1 or child was in significant cyanosis. So all patients were tried for transfemoral route. If we failed femoral route, then we went through the jugular route. If this also failed, we went through ductal route. Retrograde. It's called retrograde. So out of these cases, 16 out of 25, 64%, we could go through femoral, we could cross and do the procedure. Jugular was required in 4 patients, that is 16%. And retrograde, after failing all these attempts, we went through retrograde route and 5 patients underwent retrograde route. So all were successful, but uh, why we were failing in these 4 cases, we're trying to understand. In 5 cases where we have to go through retrograde, we're trying to understand our data analyzing that why we're failing and when do we need to go to retrograde, and can we directly go to retrograde route? If we know beforehand, I will not try these 2 modes. I will directly go to retrograde route. So we're trying to we try to analyze that data and try to understand the physiology. So in our cases, most of the times in 2 patients, we were having ventricular arrhythmias because of RV was dysfunctional. And as soon as wire was entering the RV, they were ventricular arrhythmias. So we bypassed the RV part and went through the retrograde route and failed to cross in 3 patients. Out of these 5 patients, 3 were failed to cross by all means, and 2 were because ventricular arrhythmias were happening. So someone has asked me for the ductal route, is it same size sheath used for femoral artery? So sheath size has to be based on balloon. In newborns, normally you don't need more than 4 French because you're going up to 8 dissect balloon. All dissect balloon which are up to 8 diameter will go through 4 French. So you are okay to go through 4 French, either femoral vein or femoral artery. You don't need to use the 5 French because all newborns where you have to go retrograde, valve is very small. So you are not going beyond 8 in any newborn. So 4 is sufficient actually. This is the data which we analyzed among retrograde versus antegrade patients. Like we had a total 25 patients, antegrade were 20, either femoral or jugular, and 5 were retrograde. So age was almost equivalent. The weight, PG1 was not significant, p-value. You see the p-value was not significant for age, weight, PG1 uses, severity of TR was same, RV dysfunction was same, Permival Z score was not statistically significant. Dysplasia were not statistically significant. Both had two patients with dysplastic Permival. So what we realized, Permival anatomy was not really a important factor in terms of annular size or dysplasia. Though number is not very high, we have only 25 patients, but in that study, we realized that it's not different. So what was different was these two factors. Tricuspid wall Z score, basically one factor was statistically significant that all these patients who needed retrograde route, we are having a tricuspid Z score of minus 2.5, less than minus 2.5. So all these patients had, see, none in antegrade route, all in retrograde route. So tricuspid wall Z score, keep seeing this tricuspid wall Z scores and keep seeing that if it's less than minus 2.5, you start thinking of retrograde as a primary route. And second criteria was severe TR. See this. Not statistically significant, but towards significance. So if the severe TR is there and Z score is small, in our unit, we try to go directly to the retrograde route. So these two criteria you should remember. Z score is less than minus 2.5, TR severe. If both are there, you are bound to use most of the times retrograde route and you do better actually. Because the crossing the tragus wall is becomes easier actually because you're not crossing the tragus wall. One year follow-up data in all these two groups, retrograde one versus antegrade, was not significant statistically, no issues with them. In terms of severity of PR, recurrence or reintervention rate, they were not statistically significant. In fact, two reintervention and antegrade group, but we understand antegrade retrograde BPV should not have a consequence on the reintervention or recurrence. The recurrence is not dependent on the antegrade versus retrograde routes. Now, based on our understanding of limitation of retrograde BPV, what we try to understand is one was need of femoral artery. Someone asked me also, femoral artery access is required in newborn. You are unnecessarily puncturing the femoral artery. But you understand, sheath needed is either 3 or 4 French, which is acceptable in newborns. We easily keep a 4 French sheath in the newborns. And in our series, we have not found any vascular access related complications. Then handling of fragile PDA by catheter. Because your PDA child is dependent duct and you are handling the fragile PDA by catheter. Can lead to rupture. But we understand you have to be soft with PDA, go use soft tip wires, J-tip wire only, not straight tip wires for the fragile PDA. And most of the time, when a child is on PG1, PDA are large, so unlikely to get damaged. This happens when PDA are small, but in such cases, when you can keep the PDA large, you are okay, and PDA should not get damaged in such cases. We did not have any complication related to PDA in our this series of 25 patients. Theoretically, the wire has to cross pulmonary valve against antegrade flow. Like in AS, you are going against the antegrade flow. So we thought, do we have a risk of perforation of leaflets on the retrograde approach? But in our series, we did not have severe PR, except only one patient who had dysplastic pulmonary valve and not statistically significant. And so what we think, this is our hypothesis, that use J-tip soft wire to cross pulmonary valve and also don't oversize the balloon. And that is a more important risk factor rather than antegrade versus retrograde route to cross or to balloon inflate the pulmonary valve. Now, this is important part. Presence of torsion or vertical PDA. This may be a relative issue. Though, vertical PDA is not seen commonly with the associated PS, but sometimes tortuous PDA, vertical PDA, because the PDA, if the vertical PDA is coming, then you have to go like this to pulmonary valve. This may not be compared to this route. If the PDA is like this, routine PDA, it's a smooth course, but here it may not be that easy to cross the pulmonary valve. This patient, this was our patient, critical PS patient, triglyceride score of minus 2.2. So we thought, let us go for elective retrograde BPV. And see this PDA, the duct was like this. So we were trying to cross the PDA, but we could not cross. So the route of this route was too long for the valve to cross the PDA. Sorry for this. Okay. I don't know what is new here. So this was the patient who had intimal damage, and we could not get the PDA. Sorry for this. Something okay. Now sequence is gone. One of the cases where I was getting a PDA intimal damage. That's why I wanted to show you. But not all patients should go for a retrograde route elective. Avoids advantage of retrograde BPV is it avoids RV manipulation to a large extent because you're not entering the RV, you're not manipulating the RV. So those who are dysfunctional RV, you're not handling them, and so RV induced arrhythmias, VTs are minimal here, and then better control balance stability compared to transvalvular route because there was backward traction transvalvular route which leads to shortening of loop of right heart and causing hemodynamic compromise. There is no shortening of loop here, and the loop balloon is more stable in retrograde route. It's a straight route actually. From the ductus, you directly go to the valve and you cross this. You are not handling the RV much. You are not handling the RA much. There's no loop here. So it's mostly straight. The PD is okay. The PD is long size and right shape. But this patient had a retrograde route pedicardial effusion because we were after failing attempts through femoral vein, jugular vein, retrograde route, we tried to cross through the straight tip terminal. Now, straight tip terminal newborn is dangerous. So leaflets are thin, RV myocardium is thin. You have a higher chance of perforating the myocardium here. So again, this pulmonary valve was crossed again with the coronary valve. Some patients and balloon dilatation was performed after pericardiocentesis. You can see this balloon dilatation being performed. There's a drainage was done earlier. It's a old dye basically, keeping staying. We had to do the pericardiocentesis first, and then we ultimately we could cross through the coronary wires, O14 wire. So this study of our retrograde BPV study, we found is feasible. Mostly you should worry about tricuspid annulus, RV dysfunction, and TR. The three factors, if they are there, then they may think of retrograde BPV as a primary route, basically. Tricuspid just score less than minus 2.5 may be a strong predictor for need of retrograde route. Advantage is minimal handling of disadvantage RV. So less risk of ventricular arrhythmias. And I understand numbers are not very huge. So I need more objective data to assess retrograde BPV as a primary route based on TV size and RV anatomy. So I have not analyzed RV anatomy actually, but we can analyze that part in some future. This is the route which we have not used, but I found in literature you can use transumbilical. So when the wire is coming through the umbilical, this will go to the PFO. So you have to make a loop in the RA, and then from RA to RV to crossing the pulmonary valve. So long course, this study particular case report has you guiding catheter till here, then use the coronary balloon to inflate the balloon. But this can be used if access is not available. Now this is a case which is a critical PS, PGE1, day 7 of life. You can see the angio now. See this RV is bad actually, ventricle flow is very less. Here, we did not have not have jugular access somehow. Patient was intubated. Jugular access was not possible in this patient. We were trying to cross almost no flow. Then we thought, let's go to ductal route. We tried through ductal route. See this. Pulmonary valve is, and now see this spot. Skip force this and see this. So again, we use a guide actually. The catheter was kept in the PDA, then we use the PD as a guide to cross from the retrograde route. So we were not able to cross through retrograde route also. So soft tip wire, and ultimately we could cross. We have found a significant advantage by keeping the catheter in the ductus actually. Maybe this stretches the pulmonary annulus at some extent, or this as a guide. We are able to cross, we are able to guide my wire towards this direction. These two factors we think, but most of the times I have found this PDA duct as a guide to cross the pulmonary wall is a useful addition in my practice. So keep the catheter in the ductus and a soft tip wire. I have stopped using straight tip wire now because newborn straight tip wires not a good idea. Not a good idea. So I have stopped using the straight tip wire now. It's in the newborn pulmonary wall dilations. Yeah, this one. It's another case. Again, this patient also was on PG1. We attempted all the routes, jugular also. Then we thought let's PDA be the guide for us and use the jugular route. So PDA and jugular. So this is the endotracheal tube. This is the ductal injection to see the pulmonary valve location, and then through the jugular route, cross the RV and try to use the PD as a guide. You see, I'm able to point my wire towards ductus. So I knew valve is somewhere here, and that's how I could do the procedure. So transjugular or transfemoral, and then using ductus as a guide actually. A few parts about the precautions. Avoiding Avoid damaging the tricuspid wall or distal artery. Use only smaller balloon length. So newborns 20 mm is enough. 30 for the three, to the middle age group, like 5 to 7 age group, and beyond 7 you can use 4 centimeter length. So avoid the longer length balloon because either it will come to tricuspid wall or to the pulmonary distal pulmonary artery. So avoid the damage to the nearby structures by length of the balloon to be 20 millimeters. Movement of balloon during image. Movement happens either forward or backward, but it can damage the nearby structures. So normally the balloon will move forward because the pull of the RV. The RV is pushing the catheter towards PA. So high chance of moving towards anterior. So I keep just a backward pull, but not too much that it because it can cause damage to the tricuspid wall. The inflated balloon cannot come to the tricuspid wall. Remember that part. So keep a hand nearby free to adjust the balloon. So two people should be doing it. One can inflate, the other person should be handling the balloon at this stage. Keep the gentle pull during inflammation to counter the push force of RBC. So gentle pull, not strong pull. Now, don't allow the large loop in RARV as it may not allow the balloon to cross and wire may come out of pulmonary wall. So not large loop, don't allow the large loop to be formed while putting the balloon over the wire. Ratio should not exceed 1.2. And what we do in our practice, prepare the balloon even before the wire cross the wall because you do not get much time. But this is a difficult step because the problem is the balloons are costly. Once you open the balloon, you may not be, suppose you don't fail in the crossing the pulmonary valve, the cost of balloon has to be borne. That's the issue. But normally we open the balloon because we open the balloon and in all critical pairs, time is crucial. Pre-dilatation with coronary balloon in pinhole openings is important. This I also learned gradually that this is important. We thought there is no need, but some lot of times large balloons do not cross, and it wastes my time. So when I have a severe RV dysfunction, opening is very pinhole, and then normally we try to have a coronary pre-dilatation that will allow the further bigger balloons to cross without putting a hemodynamic compromise on the RV. One more precaution while removing balloon, we don't keep the stiff negative pressure, keep the soft negative pressure because this may lead to sharper balloon edges, stiff wings, which can cause damage near to the nearby structures like this. See, this is the inflated balloon, soft edges. But these are the deflated balloon with high negative pressure. See this, edges become sharp. This we tried in our cath lab, and we found the edges are very sharp. Like if I keep them very negative, so don't keep them too much negative. Make them negative. Leave some fluid. Maybe that is a better idea whenever you are coming across the tricuspid wall. Again, inflation diffusion time to be kept at less than 10 seconds. All balloon dilatation basically. Again, this is the important part. Dial dilution for optimum visualization. In a smaller balloon, in newborns, when you are using 5 to 10 mm, 1 to 3 is better dilution because balloon is not seen. Smaller balloons are not seen when you make them 1 to 4 or 1 to 5 dilution. More than 10 mm, the guidelines are 1 to 4 dilution. If they are less than 10 mm, you use 1 to 3 dilution. So that you can see the location of balloon properly when they are being inflated. Now, this is important. I think we all see this. What if permeable gradient persists after balloon dilatation? Acceptable, we know, is less than 20. If it's persisting more than that, then view again image. If you have disappeared the waste adequately, most common cause is infundibule hypertrophy. You have taken the adequate balloon size of 1:1 ratio, waste has disappeared completely. That means balloon dilatation is done. And that means most common cause will be infundibule hypertrophy. You can see by echo also. Sometimes you may do an RV angio to define the infundibule hypertrophy. And as you understand, there is dysplastic valve, thick immobile valve, hypoplastic annulus, no post prenatal dilatation. This may not respond and needs surgical excision. In such cases, we can accept 40 gradient also. Giving the PR is not a good idea. You accept some PS. Actually. Now, infundibular hypertrophy after BPV. See, this is the infundibular hypertrophy. This is the balloon. And this can lead to significant RV pressures in the when you do a pullback. Pullback, keeping an eye on the pullback and keeping an echo guidance available, you can diagnose this phenomenon. And then there's a concept of suicidal RV, which is also explained by this phenomenon. So let me explain to the concept of suicidal RV. It's a very important question for DNB students. Before BPV, infundibular hypertrophy was there. Also, but not seen because raised RV pressures keep this open. So infundibular hypertrophy is not seen, which was already there before the BPV also, because of raised RV pressure. Now, if you do the balloon dilatation, RV pressure is fell down, but now hypertrophy comes into picture. They show their effects. And this muscle clamps down on inside, creating dynamic RVOTO. This can lead to sudden collapse of RV because there is no integrated flow happening for some time. And that is called suicidal RV. Basically, both concepts, infantile hypertrophy, exaggeration of infantile hypertrophy, when the RV gets chinked out, you may have a suicidal RV. RV may become standstill. I have seen one case of suicidal RV in my life, and RV becomes total standstill. RV doesn't heat. You don't know what is happening. Once you see this, you say, what has happened? I don't know. RV is totally gone, and you give some fluid, wait for some time. Some people advise septostomy, but normally PFO dilatation to maintain the cardiac output. But in my experience, just give volumes, and wait for some time. This should sustain. Like after 3 months, this is not my case, but after 3 months, RV infundibulum gone. So infundibular hypertrophy after BPV, fluids and beta blockers are commonly used. Time is the most important thing here. You have to give time. These drugs may not help. Immediately fluids and beta blockers. Few of the complications of the procedure. Pulmonary wall disruption due to oversizing of balloon. The management is only in surgery. You have to pulmonary wall disruption means surgery. Branch PA disruption is not common. They are stiff branches. They are not common. Mostly this happens because of stiff wires, trauma, and mostly wire. When you're pushing the wires, stiff wires in the branch PA, straight tip wires, then this is basically minor injury, and most of the times conservative management is possible. Heart block, rhythm disturbances, VT, SVT due to wires or catheters. Just, just keep the tension low, loop the wire, keep an eye on the loop of wire, and you should be good. So this is not uncommon phenomena. We all see it, but if it's persisting, you have to understand why this is happening. and try to find the phenomena of tension or loop, which wire tension catheter is causing trouble. Try to release that wire. Cracks or injury, you have to try to pass through central orifice. Don't push and pull. Also, when you're doing the balloon inflation, keep an eye that it's not backward movement, so that you are not entering the tragus wall area. While removing deflated balloon, observe carefully. Don't keep not lot of negative pressures, and don't issue resistance. Just release the deflation pressure on the balloon. You can have a sharp edges causing the tragus wall edging and hitting the valve and causing damage. Tamponade, I have seen few tamponades, mostly thin RVT, and always whenever I'm desperate to cross valve with straight tip, I have found this. Even turbo 2.5 straight tips, I have caused tamponade newborns. Thin RVT newborns is the main reason. Suicidal RV, sudden infundibular muscle enfolding, give volumes and beta blockers, and give some time to the RV. Burst balloon. Burst balloon, if you are using 5 ml syringe, Tashak balloons will not rupture. Because with hand pressure, if you're using 5 ml syringe, hand pressure, this cannot generate pressure more than 2 to 5 atmosphere, and you should not be bursting. As soon as the waste disappears, you release the pressure. Most of the times, 5 ml syringe, so you will not burst the Tashak up to 8 ml. So use always 5 ml, not 10 ml. The balloon ruptures are two types. One is longitudinal rupture, rupture like this. One is circumferential rupture, like this. This part gets ruptured, and this part here in two parts. This is we have seen long-term rupture. It's commonest phenomena. You take the balloon out. Normally, there is no complication. But in circumferential rupture, this part has to be snared. I will describe the snaring part in my next lecture when we talk about clogged balloon dilatation. How to snare this part, circumferential balloon rupture. I'll not cover today. Hypotension arrest in critical PS while passing wires, catheter balloons is not an uncommon phenomenon. We all have seen this. So do a gradual dilatation, keep the balloon ready. So when the critical PS, tiny flow, use gradual dilatation, use coronary balloon, and be ready with the balloon. But you don't waste time preparing the balloon. Pre-perfusion injury is not common because most of the time these patients are on prostatin, already flow is established in the pulmonary circulation. But those who are critical and duct is not open, you should consider this diagnosis when you have pulmonary edema or blood coming from ET tube. This one, it's a long time back. Again, I was using straight tip wire, the severe RV dysfunction and through antegrade route, and we thought we have crossed the valve, but this is a pericardium. This route we should have understood that this is a pericardial effusion and not a routine route for the BPV. This is again, I have always found whenever I have straight permo, this has happened. This one we tried after pericardiocentesis. This patient underwent balloon dilatation by other routes. So ductus was used to localize the valve, and then ductal injection to guide, and then that's how we could cross the location of the pulmonary valve. You can see the pericardiocentesis sheath here, the pericardium. So this was balloon dilatation performed through antegrade only. Ductus was used at the guide only. This is the pericardiocentesis catheter. So take home message. We know BPV is effective and safe. Units need extra care. Keep all the hardware ready and good anesthetist. Keep option of different access routes. So in a critical patient, we keep a jugular line already in place so that we don't hesitate to use a jugular line if femoral vein route fails. Avoid oversizing of balloon to achieve results. Keep some PS, leave some PS. Don't push pull across tragus wall. This is a very common mistake for the newcomers. TR injuries, lethal. This will not forgive you. Always use continuous monitoring. Keep an idea of that when to use retrograde route whenever you want to you're dealing newborn, you should know when to do I want to use the retrograde route. Taxol size and jet score should be kept in mind when you're thinking of deciding a route based on taxon morphology. So thank you for this presentation. Any questions, I will take it.